Okay, Shiv, are you able to hear us now? Hi, Shiv.
Hi.
Okay, let me. Okay, so why don't we go ahead and get started here? So we'll talk about trauma of the cervical spine. We'll talk about bones, and then the cord, and then hemorrhage around the area. So, Sahar, why don't you start with this one?
Okay. 29-year-old female with neck pain after trauma. So we see strengthening of the cervical lordosis, and there is some widening of the right pre-dental space on the adult view.
So where here?
I think there's some widening on the right side. There's a symmetrical.
Here and here.
Yeah, I think the space on the right side is wider than the left.
Okay. We also see a lot of thickening of the soft tissue swelling here. Okay, if we go to the CT scan, here's what the CT scan shows.
Okay. So I don't see a definite fracture. Okay, so there is fracture of the
through here. So you're right about that space. I wouldn't have picked that up on the plain film. There is asymmetry here, and there's a little asymmetry here. The edges of the lateral processes, and this probably is widened here. But certainly you see the straightening of the lordotic curve and the setting of acute trauma. When you see this amount of soft tissue thickening, then you've got to be highly suspicious of a fracture with a lot of hemorrhage into the soft tissues. The oblique images are a little bit, but there's actually separation here. And then if we go to the axial images, this is what we see, fracture through C1. What's this called?
Oh, Jefferson. Yeah.
Yeah, so this is a Jefferson fracture. Yeah, and not a good thing to get. Something you've really got to stabilize. Okay, next.
Okay, so coronal axial MR. See, there's contusion in the vertebral body and lots of soft tissue, hematoma, along that vertebral body. So, fracture. It's a perivertebral hematoma.
Okay, here's a CT.
Okay, so there was a what do you call bridging osteophytes there, probably fracture through the that osteophyte.
So you have these flowing bridging osteophytes. It's actually a dish with a fracture of the osteophyte. Yeah. So, let me see. So dish is a diagnosis that a lot of people use. And anybody know that? What's the diagnosis of dish? What criteria do you need to make that diagnosis? Anybody know?
It's more than 4 levels.
Yeah. So basically, you should have really flowing osteophytes and producing fusion of at least 3 vertebral bodies. Some people say 4, like this. And what's it caused by?
Anterior longitudinal ligament.
So it's really ossification of the anterior longitudinal ligament. And some people consider it a disease of unknown etiology. My guess is it's just a prominent form of degenerative disease in people who like to make a lot of bone formation. And it can lead to decreased motion of the spine. You're basically fusing the spine, and therefore you have a risk of trauma above and below the area of the dish, but just like you would if they were surgical fusions, where you can get fractures through it like we're seeing here. Okay?
Neural neck pain, upper lower limb weakness, ball abdomen. This also looks like dish and clearly a fracture.
Yeah. So this is a fracture again through dish. in this case near the cord. And patients with these kind of lesions really do have a poor prognosis. They don't heal very well, and you tend to get a lot of neurologic damage when you have these kind of fractures. Okay, Shiv.
5-year-old neck pain after minor trauma. So again, we see flowing ossification anteriorly and bridging ossification, and it looks like a fracture of the osteophyte at C3-4.
Yeah,
anterior.
and there's a big step off here, right? There's a CT. There's the MR. And here we can see that there's abnormal signal intensity within the cord, which also has a negative prognosis, meaning an injury to the cord. A little central stenosis here. And another term for this that has been used is Forstier's disease.
Term for what?
What?
That's a term for what?
For dish. Yeah. Radiologists like to use dish. The internists and so forth like to use the term Forstier's disease. So, okay.
23-year-old female with ankylosing spondylitis and neck pain after MVA. Okay, there is. I'm not sure if I see it. Is that a fracture or there's some lucency in this C2?
You can see a lot of fusion here.
Yeah.
It's like probably some anterior soft tissue thickening there. Let's see. Ah, that's a swimmer's view. It's hard to see on the projection that you have. There's a little step off right down here.
Okay.
And but the patient was discharged from the ER on 11/10/2001. Let me show you on the.
Oh, okay. There is.
Yeah. So you can see that there. You guys can't see it there. Hopefully online they can see it. But there's a little step off right here, which was not seen in the emergency room. The patient had increasing neck pain and presented at an imaging center 6 days later with this.
Oh, there. Okay. So there is 3, 5, 6. There is fracture of C4. Yeah, C5, C6.
2, 3, 4, 5, 6, 7.
6, 8, 7.
6, 7.
Yeah, posterior angulation.
And there's a CT scan.
Okay, again, it seems that there is some protrusion into the spinal canal. There is anterolisthesis at C67 level. I assume there's cord compression at that level. The posterior elements are also involved.
So you fracture go through, and this is a very unstable lesion. It involves both the posterior, central, and anterior components of the cervical spine. And there.
Come over and look at that.
What?
The X-ray. I just kind of want to see the X-ray now. Do you mind? Sorry.
Sure. Come look at the X-ray. It's a swimmer's view.
Thanks.
Okay. And then, so there, so we can see that. So what do you see here on the CT scan?
Okay, on CT, looks like we have like perched facets, I think. There's fracture.
Okay, so this patient, so we can see that there's an extensive fracture involving all three columns of the spine. So it's a very unstable fracture. Admitted to the hospital at this time, however, the patient was still neurologically intact.
Okay.
And this was the MR scan done inside the hospital. And at the time the patient went in the scanner, the patient was neurologically intact.
Okay.
But okay, so here we see very unstable spine. Those are the axial images. Then the patient returned to the bed, and as they were moving the patient onto the bed, they developed quadriplegia. at this particular
Oh,
time.
okay, so there is,
And they came back and had an MR scan
there's
the
cord
next day.
contusion. Yeah,
What do you see?
there's cord contusion at that level C67. There's edema in the cord.
We don't see much acute hemorrhage on the T1, but we can see there's extensive edema within the cord.
Is there a brace in place now? It's like the alignment is back almost.
Yeah. Yeah, you can. And this is 4 years. 4 years later, the patient was still a stable but quadriplegia. So, I just want to point out how easy it is to miss some of these lesions. You have to be very careful with the swimmer's view if you're in a hospital emergency room setting. But even though it was initially missed, the patient was fine until they are actually in the hospital and were transferring from the bed, and then obviously they weren't protecting the spine adequately in the hospital, moving the patient around. So quadriplegia from fracture. Okay, next.
Okay, so multiple sagittal views. Mid-thoracic level. There is indentation of the spinal cord. Right. So.
So what's happening at that level?
Posterior element. So epidural space, posterior epidural space, I don't see it.
So there's something here posteriorly.
Right.
Here. Here's one axial image. Above it, where it looks fairly normal. That's what it looks like at the level we're talking about.
Right. So that hypointensive compressing the cord, is it?
It's this stuff right here.
Right.
And that turned out to be compressive neuropathy from ligamentum flavum hypertrophy. Probably calcification.
I see that again?
It's a huge one.
Yeah,
It's very focal.
yeah, very focal.
Big, yeah.
Lower
Patient-
down.
Maybe another one, yeah, lower
There's
down
another
too.
one down here too. Yeah.
Can we see the axial? So can you point to it here, please?
That one dark thing.
Here it is right here. And you see compression of the cord. So this patient went to.
It's more posterior, isn't it?
There's another one more posteriorly too. And this patient actually went to surgery, and that's what was found.
What's with that? Ligamentum hypertrophy, where's that from?
It's probably from old trauma. I've seen, actually, the chief administrator at a hospital I was in many years ago was a football player for many years, and he had a big calcification that was compressing the cord in his lower thoracic spine. And he was pretty asymptomatic with it, but there was significant compression about like this, and they elected not to do anything about it. As far as I know, he's still okay.
It's also calcified, probably.
This is probably calcified too, right? Okay, who's next?
16-year-old postoperative. It's not an anterior fusion hardware. Alignment looks okay.
Okay, so everything looks pretty well. So it's hard to figure out what the symptoms were due to. So they decided to do a fluorine bone scan.
How long after surgery is this?
A while. I don't know exactly how long,
Okay.
but not immediately after surgery.
Okay. So I guess depending on the time frame, you wouldn't necessarily expect to see active bone formation surrounding the hardware. So that would indicate that it's probably loose.
Yeah,
The
so
hardware's probably loose.
probably that's what the feeling was. I think they ended up not operating on this patient, but the belief was that this shows up subtle instability that you really can't see with other techniques.
It's really the inter body discs that were lighting up. Maybe little end plates, I guess. Right?
Yeah, I think it's Yeah, I think this is a disc space level there, and this is a disc space level there. Okay, all right. Shiv, what do you think of this case?
Okay, 48-year-old upper extremity numbness, pain 2 years after surgery. So I do see an ACDF from 4 through T1, C4 through T1. Nothing really jumps out at me with the ACDF. It's okay.
Okay.
Some mild. It looks like there's incomplete fusion or lack of fusion of the 4-5 level.
Right.
Uh,
Right through there. And here's what the CT scan looked through that level. And
yeah,
this
it looks like
patient was
fusion.
continued to be symptomatic because of lack of good fusion at the 4-5 level and instability.
64-year-old female with neck pain 8 years after surgery and progressive neurologic symptoms 1 week after epidural injection. Okay, there is anterior fusion at C5, C6, C7.
5, 6, and 6, 7, yeah.
And there's fusion actually. There's fusion of the vertebral bodies and some protrusion. Posteriorly, there's abnormal cord signal and yeah.
Okay.
So 2010, it looked normal back then. Looks new. They did the epidural injection. Could be focal infarct, acute infarct.
And there's the prior and the current study.
Okay, we see the linear signal from the cord.
And at another level, this is what another level looked like.
Okay. Same thing.
So they basically injected the cord at 3 levels. So it wasn't an epidural injection, it was an intracord injection.
So what happens in a situation like that?
I only followed this patient for a few months later, and they were pretty neurologically fairly stable, but they didn't improve a lot. So I don't know what ended up happening, but just MR findings of things you hope not to see. Okay, next.
Okay, so pre and post epidural. So small disc C5, C6, and there, and then like linear increasing in intensity at C6, C7 level. So
Right here.
right, so non-specific.
Okay, yeah. So that was another cord injection in someone who's supposed to be doing epidural injections. Okay. Sam?
Football impaction. Okay, the cord is obviously really thick in this increased signal. I think
Yeah,
that's owl.
maybe some of it is a kind of a poor study with some motion artifact.
Okay, and then there's that focal increased uptake in the body. Yeah. I wonder if there's some loss of height there.
Yeah, it's not obviously it's edema. It's increased free fluid, right?
Yeah.
Within the vertebral body, and that's what it looked like on the axial plane.
There, but there's not, I mean,
Here's what it looks like on the CT.
okay. It looks like more chronic than. I think it's kind of chronic, and it's probably Schmoll's or degenerative thing. The disc under it is the.
Yeah, this was I think the day of or the day after his injury playing football. There's reversal of normalotic verge, and I think what this is an acute Schmoll node. It's basically an impaction injury where the nucleus pulposus herniates through the end plate into the vertebral body.
So why no? It's acute. Why isn't there edema on the MR?
Well, I think there is. Yeah, I think it's. I think it's just a kind of a sharp fracture there. Yeah. Okay. So that's a facet cyst. What is that here? And this just shows a calcified facet cyst also producing neurologic compromise. Why do I have degenerative disease in here when we're just talking about? This just shows some facet degenerative disease, but this is supposed to be a trauma section. Oh. Okay, so here's a patient, Shiv, who came in with, okay, this patient came in with chronic neck pain. This is a CT scan. These are sagittal reconstructions from an old CT scanner on the right side and the left side. What do you think's happening?
Okay, so it looks like the right side looks relatively normal. I think the left side looks abnormal. I think there's a facet dislocation, maybe a unilateral facet dislocation or a perched facet.
Yeah. So, aren't you guys glad that you didn't live back in the days when CT was starting and this was state-of-the-art CT imaging? Okay, here are the axial images, which are a little better.
Yeah, so on the left, it looks like there's a reverse hamburger, and it looks like there's a dislocation.
Yeah, that's a level above. And this is...
It looks like there's significant widening of the left neural foramen, which makes me think it's been there for a while, or congenital possibly.
Okay. And this is when we get down to more normal level below. And this was thought to be a congenital facet dislocation. My guess is this is just an old facet dislocation. And when the bone remodels after it being there for a long time, these are the kind of deformities that you could see.
Okay, it says that we have disruption of the posterior longitudinal ligament at C5, C6. Yeah, and yeah, there's some angulation posteriorly toward. I'm not sure if there's any abnormal symbol in the cord. Yeah, the facet doesn't look normal too. It looks like there's perched facet on that side.
Yeah, right there. Good. So this was an acute trauma. The last one was chronic. This is an acute trauma, and this is a unilateral facet dislocation. But this was an acute one, whereas the old one was a chronic one. And you can see abnormal widening of the neuroforamen on that side. And as you said, there's perching of the facets back here. And you can see abnormal spacing here in the spinous processes, which are characteristic of this. Okay.
So, oblivious the cervical spine at 2, 3, 4, 5, 6, 7. 6, 7. I don't see the foramina well. Something getting into there.
That's on the left. Here we have the right. Here's what the MR looked like.
6, 7. You have a disc herniation.
Okay, and then well, yeah, maybe there's a little uncovering of the disc here, but there's a little bit of malalignment here.
Right, and minor space is there.
And if we go off to one side, this is what it looks like.
Okay, lots of fluid signal within the what do you call between the two facets. So maybe facet.
So what's happening here? This is normal.
Right. So it's parched actually. It's crossed over.
Yeah. So this is another unilateral facet dislocation or unilateral facet jump facets, where this should be behind.
Right.
The inferior facet of the upper level should be posterior to the superior facet of the inferior level. So this is a unilateral jump facet, right? Okay. Sam?
Seminal neck pain and weakness. There's substantial ankylolisthesis. Yeah. a lot of the changes there look chronic, but there's also edema, so there's some acute chronic process
Yeah.
going on.
And that superior end plate doesn't look normal. This is very abnormal, the inferior end plate above it.
Yeah.
And there's a lot of other degenerative stuff here too. And then we can see the cord looks kind of kinked. But now if we go to the sides, that's the right and the left sides.
Yeah, well, on the left there's some torching. On the right, also, yeah.
Yeah, but right here, the facets are jumped again. And this is another chronic unilateral facet dislocation. Yep. And you know, it's chronic. You can see that all these long-standing degenerative changes here. Yeah. Well, the edema is just the abnormal stress pattern through the abnormal. And here it's a little hard to see at this level, but these facets, they're degenerated, but they're still normally aligned. Here, this is abnormal, and it's jumped right here. Okay. Shiv, what do you think of this case?
Okay, 70-year-old with neck pain for 3 weeks, shoulder weakness 3 months after head trauma, rule out cuff tear. So I see a significant amount of edema within the, looks like the infraspinatus, and I think that maybe there's a retracted tendon there. It's hard to tell.
It's hard to tell on this, but we certainly see a lot of edema within the supra and infraspinatus muscles. Here are the coronal images.
Yeah, similarly, a lot of edema there. And there, it looks like the looks like there's edema, and it looks like there's the tendon doesn't look normal. It's lax, and there's probably some degree of tearing there.
Okay.
And here it looks like there's quite a bit of it looks like there's anterolisthesis of 4 on 5.
A lot of edema in the muscles. Here's a plain film.
Okay, so yeah, it looks like anterolisthesis of 4 on 5 with perched facets there, and the prevertebral soft tissues look okay.
There it is.
Yeah, it looks like there's dislocation here on C45.
Yeah, again, you can see very degenerative facets here, but it's certainly perched on one side. Yeah. And it was thought that all of that edema that you saw in the shoulder was actually due to denervation changes from the cervical spine disease. So the patient had surgery to reduce it and stabilize the cervical spine.
Got it.
Radial rollover injury. Okay. There's a lot of edema and hemorrhage in the interspinous muscles.
Back here, you mean?
Yeah.
And through here?
And it's going over superior, I think it's from like upper cervical spine to that level. And that looks like the ligamentum flavum. Maybe it's torn.
There's the axial image through there.
Axial. Fracture of the tip of the spinous process, some edema in the muscles.
Okay. Right. So this was a hyperflexion injury, and it actually tore the muscles, and it actually also tore the interspinous ligament between the spinous processes. And yeah, and we can see the widening of the interspinous processes here. The central column and the anterior column look like they're grossly intact. But there you can see the posterior changes from the hyperflexion injury. Okay.
Okay, so lateral view of the cervical spine. What is that? Okay. Anyway, so there is a, I would say, anterior subluxation. I mean,
Yeah, so we have this. Well, we probably have dish here.
right, C3.
Another fracture.
Right, C3, C4. With lots of increasing in the posterior paraspinal, posterior spinous area and interspinous area. And arched, widening of the basic gap between the two.
Yeah, so the facets look like they're perched there.
Right.
Here in the midline, we can see the spondylolisthesis and the central stenosis.
Right.
This is another hyperflexion injury. This one a little bit more severe with more instability. Okay.
Like 8 months after surfing, this is a C12 injury. It's like
Wait, see what two? Let's see. 2, 3, 4, 5, 6, 7.
Oh, okay. So soft tissue injury, interspinous ligament tear. I guess was torn. And some fluid over it.
Yeah. So this was another hyperflexion injury with the tear of the. Yeah. Okay. Shiv, what do you think of this case?
Okay, young man, 24 years, RTA. Okay, so it looks like there's, is that a fracture? It looks like there's posterior retrolesthesis of C4 on C5, pretty significant with edema within the cord. Not certain if it's fractures.
Yeah, and a lot of
prevertebral
posterior soft tissue swelling and hemorrhage.
Right. So
Here
yeah, there it looks like there's significant retropulsion of C4 with a significant narrowing of the spinal canal. And at that level, there's severe narrowing of the spinal canal and deformity of the.
So actually, one side of the vertebral body was more displaced than the other here. You can see there's really a vertical fracture through both the anterior and posterior elements here.
Yep.
And the cord ended up herniating through the dura here, the tear in the dura.
Wow.
And surgery.
Ouch.
So it's a transdural cord herniation.
Your male left hand weakness, atrophic changes for 3 months, left ulnar and radial neuropathy. Okay, the alignment looks okay. There is some abnormal cord signal at that level. Okay, we have T1. There is some prominence of the epidural space, I think, at that level.
Yeah.
Like herniation?
So this is a kind of a controversial diagnosis. It's called Uryama disease. Have you ever heard of that? Okay. It's cervical myelopathy, and it's related to hyperflexion of the neck. It tends to be seen in kids, and it can occur after going to roller coaster rides and so forth. And it's believed to be due to repetitive trauma to the cord. There's atrophy here of the cord in this area, due to repetitive impaction of the cord due to hyper motion within the cervical spine. And you can see focal ischemic changes on histology, and you really get kind of a progressive neurologic long track signs. So, and some people believe it's an imbalanced growth in these kids, or a tight dural canal with increased flexion and extension, which compresses the cord repeatedly. Okay. See.
So, epidural mass on flexion images. Yeah, so lots of flow words, I think, over there in the epidural area. Also, the spinal cord there is increasing.
Yeah, actually, this shows a normal spinal cord here on the images from my computer. This is abnormal here. So you can see that the cord is abnormally positioned and flattened in the patient. Okay. There, the T1 weighted, that's different. That's different. So, and this is another case where it's thought that there was a hypermobility at this level, which was basically contusing the cord. Okay. All right. Let's see. Next.
Okay. So is that real edema in C2?
Yeah.
Is that a fracture?
Yeah. This is so. There's a lot of degenerative disease here, a lot of central stenosis, a lot of disc disease, and what this patient ended up having was actually a fracture of C2, and was relatively unstable at that particular level. But you're right. You picked it up right away, but it's easy to miss these, and you can often have a little synchondrosis there that can be congenital. That can be, so occasionally these are misinterpreted as normal, but that's a C2 fracture. And at that level, these are typically unstable fractures. Okay, Shiv, what do you think of this case? Neck pain after trauma.
Okay. Looks like the C7 sinus process has a little bit of edema, maybe, and that could be artifact.
Here's the axial images through there.
Yeah, it looks like a little spinous process fracture, maybe.
Yeah, this was another flexion injury, and probably a little tearing of the interspinous ligament from the spinous process there. Good.
Okay, there is exaggeration of the cervical lordosis. Looks at 667, and there is it's like a fractured spinous process. Yeah, it looks more chronic. Like here.
Yeah, so it's a spinous process fracture. This was C6. Often they occur at C7, but this is probably 2 levels here and also there. Okay.
So left back pain for 2 weeks, chest X-ray. See from here.
Yes. Can cheat.
Have to see any disc, vertebral, very hard to see from here.
Yeah, it's hard to see much.
No, so bone window. The spinous process fracture there. Some total thickening. Okay. Is that a rib?
Okay, all through the eyes.
Rib fracture?
Yeah, so this is a stress fracture of the rib. I find these difficult to make a diagnosis on X-ray based technologies. And so we usually evaluate these with MR, but well, you can certainly see displaced rib fractures on plain radiographs and CT, but sometimes they can be very subtle.
When is MR indicated for them?
Well, MR typically is indicated in athletes where the problem is usually tears of the muscles, usually the obliquous muscles. And often we do the MR for the muscle tears because CT and even ultrasound aren't very good for those. And sometimes we'll see the muscles are okay, but we'll see edema within the ribs, which would be the stress fracture in the ribs. If the concern is just a rib fracture and a non-athlete, then you just usually treat it conservatively and you don't need to really any imaging. Sometimes people get plain films because they think it's cheap just to see it, but the plain films are often negative. But in an athlete where you need to make the diagnosis to decide how long they're going to be out of playing and so forth, then we typically get an MR for those. But usually it's more of a muscle tear rather than a stress fracture, but occasionally it's a stress fracture. Okay. And here are just some typical fractures that have healed. Okay, let's see. Okay, so who's next? Who? Tim?
It looks like the dens is like too proximal relative to the skull base and C1 anterior arch.
You're talking about in here?
A little higher even.
Okay. Well, there are the plain films, and here's a CT.
This is a posterior arch fracture. That's C2, I guess. Oh, and then body fracture.
Yeah.
Not so sure about. I mean, the alignment didn't look that bad on the.
Yeah, let's go back here.
These are
So,
true axils.
Get into a pool. It's really.
Oh yeah, oh, sorry. There's straightening. There's a lot of substrate edema anteriorly. Yeah. There's some straightening problem. We don't see very far down here, so
Yeah,
I wouldn't even try.
So here are the axils, and here are the sagittal reconstructions.
So, of course, our X-rays didn't go down this far. Usually, we expect to see it all the way to C1. But
C5.
I mean, if I were reporting
3, 4. So it's right here.
yeah, the first thing I'd say is that we don't see lower than C4 in here. If I was reporting.
Right.
Yeah, sure enough. So they're just hiding in the shoulder, I guess.
Yeah.
It's just like a burst fracture of
Right.
the body.
And you can see.
Yeah,
right here. And CMR scan. Yeah, and see a lot of cord disease here. And this patient was quadriplegic after doing this. Okay. Shiv.
Okay, 26-year-old motorcycle accident 2 days ago, neurologic deficit. So it looks like there's multiple fractures here. It looks like the vertebral body's fractured and both of the pedicle or the lamina are fractured.
Yeah.
It looks like there's probably some retropulsion maybe of.
Yeah.
Yeah. So yeah, it looks like retropulsion of the posterior osseous fragment. And it looks like the soft tissues posteriorly are really swollen and there's probably hemorrhage there. And
Certainly a lot back here. It's a relatively subtle anteriorly, but that's abnormal as well. Here's the MR scan.
Oh yeah. So big hemorrhage and edema in the soft tissues posterior.
And obviously this is a very unstable fracture involving anterior middle column and posterior column, and then you got the contusion and probably some hemorrhage into the cord.
Right.
Okay. There you go.
4-year-old male, 4 months after being run over. Okay, there is a kind of like large epidural space at the lower cervical spine, upper thoracic spine. So we have this. There
So
is
what's going
significant
on here?
compression on the cord. It might be cord infarct, chronic cord infarct. Well, just expect dilatation of the epidural
Yeah.
space.
So this is post-traumatic cord atrophy
Okay.
because of damage to the cord at the time. And so this is really all atrophy of the cord, and then you just have CSF filling the space. Obviously, very poor prognosis.
38 years old with neck trauma, fell from tree.
Only kids should climb trees.
So C5, there is center inferior, increase prevertebral soft tissue and C5 fracture, anterior inferior corner fracture. Yeah, and lots of the cord is thickened. Increased signal could be contusion and hematoma within the cord, and lots of posterior things deep. So it's acute unstable. Yeah, pars.
Yeah.
Also.
So another unstable fracture with significant cord contusion and a lot of soft tissue hemorrhage. Another bad prognosis with signal like this within the cord.
What is that signal?
What? That's hemorrhage in the cord. Like gradient echo sequence. That's hema. That's all dephasing from the heme component. Okay.
27-year-old motorcycle accident, walked away, then had leg numbness, went to the hospital for surgery. That was 2015, so about a year later, quadriplegic, use of the surgery. Okay. Interesting. So there's the surgical hardware and a lot of cord injury at that at the level of the.
Yeah, it looks like it's transected. So that's one level. This is the next level. That's the next level. There. Going down through the lesion until we get to the other side. Yeah. So he basically had a transected cord. It's just interesting that the symptoms were delayed that much. I guess the bottom line is you need to get your cervical spine stabilized sooner rather than later. Okay. Shiv.
Neck pain after trauma. And let's see. Looks like C2, 3. I'm not sure I see.
So we're off to the side. Look at this area right in through here. Let's, and then if we go to the CT scan, here's the CT scan.
Okay, so it looks like there's a fracture of the sort of left pars area. Or
The problem here,
pedicle.
this is not the greatest scan here, but when you get distraction injuries of the bone, sometimes you don't get a lot of bone edema. And so here we can see it very nicely on the CT scan. And do you know what the name of this fracture is?
Hangman.
Yeah. Hangman's fracture.
Okay, 47-year-old male, 4 months, well-known and back pain, gouty arthritis for 5 years. So there is some compression fracture of the, actually, it's at multi-levels.
Yeah,
That
but
one,
it's not a typical compression fracture
yeah,
because
it's
it
linear
in an
actually.
anterior compartment, mid compartment, and posterior compartment. So this is really an unstable type fracture. And then here we can see
the same thing.
the fracture lines going through there. It's a little bit of compression, but it really goes through the spinous process here. And the name of this fracture typically occurs in the lower lumbar spine, typically in auto accidents with people who have seatbelts.
Seatbelt injury.
It's called a chance fracture. Yeah. Typically from seatbelts, but now with shoulder straps, they're less common. And it just shows this was Dr. George Quinton Chance, British radiologist in Manchester, who described this kind of fracture. It goes in the horizontal plane through the mid-body into the spinous process. Okay. Next.
So, CT and MR, 26 years old, back pain after dropping. So, again, seems like, I don't know exact level, there is a compression fracture.
Yeah.
And so I am not sure whether, maybe there's some posterior elements that are also involved. So maybe another chance fracture.
Yeah, and this is more of a kind of compression flexion type mechanism, but still it does the same kind of fracture. Now, if you get out and you see trauma, then you'll need to work with your neurosurgeons and see how they like to classify it. This is one classification scheme where you describe, so what you need to describe is the morphology. Compression fractures tend to be relatively stable, burst fractures a little bit less stable, translational rotation, and distraction injuries are the most unstable. And then whether the neurologically they're intact or not, obviously what the cord looks like is very important. And then the posterior ligamentous complex is very important to determine instability. And you can add this up, and above a certain number can be surgical or not, but most of the surgeons that I've talked about don't actually add everything up and determine the number as to whether they operate or not. They operate basically on the symptoms, and this I think is more for doing research studies. But these are the things that you need to, certainly the morphology of the fracture we need to describe in our reports because that's important, and involvement of the posterior elements is very important for stability. The posterior elements are important stabilizing factors. So those are the two main things that we need to talk about, as well as the cord, obviously, in any neurologic problems. Okay, who's next?
Sam.
6-year-old back pain for 1 month.
Normal or abnormal?
It's another chance fracture clear through and significant posterior translation of the upper spine.
The patient he's already has a fusion up above. Yeah, and this completely transected the spinal cord. Okay, Shiv, what do you think of this one?
All right, 16-year-old male post-trauma. So it looks like at the C5-6 level in the spinal canal, there's that abnormal signal.
So you got this little dark signal here and a little bit of increased signal intensity within the cord.
I don't see any disc disease. Okay, so now we have some axial images. Okay, the cord seems to be shifted to the left a little bit. I don't see the right spinal nerves, really.
Okay.
Yeah, there it looks asymmetric. I don't see a right exiting nerve root. So he has some sort of injury to maybe his spinal nerve root.
Okay. And here's some of the oblique sagittal images. In this case, kind of oblique.
Yeah,
you can see the nerve roots and something
higher up
here, a little bit of a edema within the cord. Here.
Yeah, the nerve roots lower at one level, lower down look completely abnormal. That level right there.
So these were cervical nerve root. This was a cervical nerve root avulsion. Right.
Ouch.
Okay. Okay. Usually it's multi-levels. So usually it's not just at one level. There's another patient who had trauma and now has a weakness in the arm,
This looks like there
left
are
arm.
multiple cystic lesions through the neural
Okay, so you have these
foramina.
big,
Yeah.
this
Yeah.
is in the foramina. Here's the axial image through one of them.
Okay, it looks like there's widening of the neural foramen with CSF, like prominence of the CSF space. Looks like multi-level meningocele.
Well, what you see is, and we'd have to go up and down, is I'm not sure, it probably isn't all that widened, but what you have is the cord is shifted to the opposite side, and we see no nerve
No
roots
nerves,
at these levels. And we have all this CSF going out through the neural canal, kind of collecting externally here, as we can see coming out through there. And these were all nerve root avulsions from trauma. It's very, I've seen this mostly in motorcycle accidents. It's not something we see routinely at RadNet, but back when I worked in hospitals and worked in emergency rooms, this was fairly typical of motorcycle injuries.
You're flexing away from the side of, I guess.
You basically have acute trauma that basically separates the neck from the shoulder on one side. Okay, next.
So coronal images through cervical spine again seems like CSF areas on the right side, so multiple avulsion.
See them coming out on the one side, but not on the other side. And those are just pseudomeningoceles replacing the nerve roots. And here you can just see the thickened, injured nerves over on that side, coming down through here. And okay, see, this is just a patient who had prior injury with a fracture, and this is just postoperative gliosis and atrophy of the cord at the level of the cord injury. So why don't we stop here, and we'll finish trauma next time, and then we'll go on to the other things. Okay?
Thank you.
Thank you.